Okay, so hemophilia is an X-linked bleeding disorder. Typically, it is prominently seen in males. It dates back to like the 2nd century, during the Babylonia times. The Talmud, which is sort of like a Jewish religious law book, stated not to have infants be circumcised just because there was a more prevalence in bleeding. They noticed a more prevalence in bleeding during circumcisions for infants. So it can date back all the way there. So hemophilia was first published in a medical journal back in 1803 by an individual named John Conrad Otto. He basically stated that hemophilia is an X-linked disorder that is passed on from unaffected mothers, essentially carriers, to their sons. And the term hemophilia wasn't necessarily used until 1823 by someone named Frederick Hopf, a student at Zurich University. Even though hemophilia is a rare disorder, it became more known because of royal families like Queen Victoria. She was a carrier of hemophilia B, and she passed that on to 3 of her kids. 2 of her daughters became carriers. I think their names were Beatrice and Elise. And her son, Prince Leopold, he had hemophilia B. He showed all the signs and symptoms, and it became more known through all of the royal families. They arranged marriages, so it was passed on throughout all of the royal families, essentially. Hemophilia is a X-linked recessive genetic disorder, and the 2 I'm going to be talking about today are hemophilia A and hemophilia B. Hemophilia A is typically caused by a mutation or an genetic alteration on the F8 gene that's located on the X chromosome, whereas hemophilia B is caused by a genetic alteration on the F9 gene on the X chromosome. So the 2 mutations I will be talking about are missense mutations and nonsense mutations. So single base substitutions on factor VIII exons that result in a different amino acid is known as a missense mutation, and this can cause like all sorts of severities with hemophilia. You can have mild hemophilia, you can have very severe hemophilia. Severe hemophilia you could have bruises from severe hemophilia that come up from, not even being hit, they just come up out of nowhere. And mild hemophilia, if you get hit really hard and you have a big bruise and it lasts for a while, that could be one of the symptoms of mild. But typically with mild hemophilia, it's not as crazy, and it's very, very manageable. So if a stop codon is signaled during the single base pair substitution that I talked about, a non-function protein will result. This is known as a nonsense mutation, and almost always nonsense mutations cause severe hemophilia, where you have the bruising and the prolonged bleeding, and people need to take they could take factor VIII or factor IX for this, but it's typically manageable, but it can take a toll on people. Okay, this is a visualization of how hemophilia is passed on to the offspring. This right here is a key. This circle represents a normal female, this is a carrier female, and this is a hemophiliac female. This square right here is a normal male, and this is a hemophiliac male. So starting at the top, as you could see, the male is normal, he does not have hemophilia. The female, however, is a carrier of the disorder. This is because one of her X's has the mutation on it. So the mutated X's I put as like a red X, so I'll refer to the mutated X's as red X's. Okay, so because one of her X's is mutated, she is a carrier. They don't have any signs and symptoms of it. They don't have hemophilia themselves. They are just carriers, so they could pass it on to their offspring. They have 4 kids together. The first son, he gets the red X. So the female basically has a 50-50% shot of giving off her red X. So unfortunately, this son did get the red X. He does have hemophilia. The second son did not get it, so he doesn't have it. The daughter here, she does not have it. And the last daughter here, she gets the red X from her mom, and she gets a good X from her dad. So she becomes a carrier of the disorder. Going back to over here, the first son mates with a female that does not have this disorder. She has 2 good X's essentially, and they have 3 kids together. The first son, the first 2 children cannot get it because they get their X chromosomes from their mother, and she is normal, so they won't have it at all. Typically, if there is a father with the disorder and the female is not a carrier, then the sons will not get it, but the daughters can become carriers to it. Well, not can, but they will become carriers to it because they get the X from their father, who has the red X. So the first X is obviously from the mom. She does not have this disorder, so they are just carriers because they get the second X from their father, who has this mutation. Okay, so going over here, the 4th daughter, she is a carrier because the first X she got from her mother has this mutation, and she becomes a carrier. She mates with somebody that is normal, and they have 3 kids together. The first 2 do not have it, but the 3rd daughter, she does get this disorder from her mother. She becomes a carrier as well to this disorder. And then she mates with somebody that has hemophilia. This is where it becomes a little bit more complicated and more rare, because they end up having a daughter that has hemophilia. She's not just a carrier, but she actually has hemophilia. This is very, very rare. So let's go over everything. The first son, he does not have hemophilia. He gets the good X from his mom, and he gets the good X, or the good Y, from his dad, so he does not have it. Then the second son, he has hemophilia because he gets the bad X from, or the red X from the mom. And the 3rd child, she becomes a carrier because she gets the red X from her father. So she gets the good X from her mother, but she ends up getting the bad X from her father. So she becomes a carrier of this disorder. And then the 4th child, the daughter, she gets both red X's from both of her parents. So she presents with the signs and symptoms of hemophilia. Like I said, this is very rare to have in a female. Usually females are carriers. So yeah, that's very, very rare. But yeah, this is the visualization of how hemophilia is passed on. Factor VIII is produced in sinusoidal and epithelial cells outside of the liver. Factor VIII attaches to von Willebrand factor through a stable non-covalent complex. Factor VIII is inactive while circulating through the bloodstream. However, when an injury occurs, this factor VIII separates from the von Willebrand factors in the presence of thrombin and becomes activated. Factor VIII is a cofactor for the factor IXA, which converts factor X into factor Xa. Factor Xa is a cofactor for factor Via, converting prothrombin into thrombin. Then the thrombin cleaves fibrinogen to form fibrin, forming an effective blood clot. When there is a deficiency in factor VIII, factor VIII is unable to interact with factor IXA as quickly or effectively as normal to form the factor X in the blood coagulation cascade that promotes thrombin production. This results in a prolonged bleeding time. Oftentimes with severe hemophilia, they have spontaneous bleeding episodes that don't have a direct, whereas mild hemophilia, if you get hit really hard, you have a bleeding episode there. With severe hemophilia, it's very spontaneous. You don't have to have like a direct blow to the muscle or anything like that. It comes on randomly. So with that, a lot of times these bleeding episodes occur within the joints, and this causes a lot of issues down the road. It's constant swelling and pain within these joints, and oftentimes the hemophiliac with the severe hemophilia, they need to see an orthopedic surgeon or a hematologist to figure out exactly what the treatment plan could result in. A lot of times it's surgical interventions, unfortunately, but in order to prevent these long-term surgical interventions down the road, the person would need to follow with long-term prophylactic intravenous therapy like factor 8 and factor 9 if they do use those medications to help with their hemophilia. With the long-term use of this and orthopedic suggestions, this could reduce the recurrent bleeding episodes within the joint and preserve the functional range of motion, as well as decrease muscular atrophy and overall just help the hemophiliac in general. Treatment plans for hemophilia. So for a good amount of time, blood was used as a go-to medication to treat hemophilia. Factor concentrates derived from blood plasma were used in the treatment of hemophilia. Then this kind of came to a halt because a lot of people with hemophilia that were using blood started to develop HIV and hepatitis C. This occurred sort of in the HIV pandemic era. Blood was not screened effectively like it is nowadays, and unfortunately a lot of people ended up getting these because of getting blood, basically. So a lot of hemophiliacs that developed HIV developed AIDS, and they had an early death due to the HIV. But the ones that did survive had hemophilia and they had HIV, so they had, increased medical costs for treating both, and they had a stigma on them back when HIV was really something really scary, and people who had it had a big stigma on them. And then they also had to, suffer the physical consequences of having both of these illnesses. So once that was seen, a lot of scientists decided to create a new medication to treat hemophilia. It is called recombinant factor. It has been the go-to medication ever since the 1990s. A lot of hemophiliacs use this medication, and they see really good results from it. It is derived from rats, but it is very effective as a prophylactic treatment. It decreases the amount of bleeding episodes a person has, and it also decreases the consequences in terms of, the joint issues that hemophiliacs develop. Okay, so in terms of half-life for the medication, it is about 8 to 12 hours. There is a medication called adjuvanate, I think that's what it's called, and it is used to extend the half-life, so hemophiliacs can use the recombinant factor and this other medication, and they don't have to infuse as much as they usually do, because some hemophiliacs infuse every couple of days, so this really helps to decrease the amount of times they have to use their medication, because it is an intravenous medication given through their veins, and this can be, it could put a toll on them in terms of, how many times they have to infuse and everything like that. The one barrier to recombinant factor is that some people do develop inhibitors within their body. So basically the immune system develops these inhibitors, which kind of stops the medication from working. The immune system notices this medication and it basically puts it to a halt. It doesn't have any effect on the body whatsoever. This is seen in 32% of cases with nonsense mutations and 11% of cases with missense mutations. This can be really bad because, as I mentioned earlier, nonsense mutations typically are seen with severe hemophiliacs. So if 32% of these hemophiliacs cannot get the proper treatment they need, it really puts a toll on them, you know, physically, emotionally, and all of that other stuff. But a new medication came out. It is called Hemlibra. It's a subcutaneous injection, and this has a half-life of 28 days, so it's way longer. They don't have to use it as much as the recombinant factor. So it's a humanized bispecific monoclonal IgG4 antibody designed to bridge factors 9A and 10 like factor 8 normally does. It's used as a bypassing agent. So this is useful for those inhibitors. It's also useful for breakthrough bleeds because it decreases the amount of times that the breakthrough medications need to be used. It requires recombinant factor, but it lessens the amount of self-infusions needed. So this is a very good source of prophylactic treatment combined with the recombinant factor. Researchers are looking for a cure for hemophilia. Right now they're looking into gene therapy because hemophilia is a single gene disorder. It is more likely to become effective and successful with the gene therapy than other disorders. So the research is still ongoing in terms of that. So with the gene therapy, if factor 8 levels do increase because of the gene therapy, they are only needed to increase very slightly because in order to avoid spontaneous bleeding, factor 8 levels need to increase to above greater than 10%, which isn't too bad. So it's a very good probability that this could be very effective, and this can change the course of this disease and also alter the way that hemophiliacs need treatment and other things, and can really change the course of this debilitating disease. Hemophilia A occurs in every 1 in 5,000 males worldwide, and hemophilia B occurs in 1 in every 20,000 males worldwide. In terms of the life expectancy, it is a lot better now than it was back in the day. Back in the 1800s, life expectancy for hemophilia was to about 14 years of age. Now, a person with hemophilia can live a long, healthy life just like we do, but of course, they need to follow their prophylactic treatment and any recommendations that their doctors and their healthcare team put into effect. But males and females can live a very long life with hemophilia. Hemophilia can be very debilitating to a person, not only physically but emotionally as well. So with hemophilia, they could have spontaneous bleeds as well as bleeds from different injuries. These bleeds can be very, very painful, especially when they are present in the joints. Hemophiliacs oftentimes do have a lot of joint bleeds, and this causes a lot of swelling and a lot of pain. This can be very debilitating, and this constant bleeding, these constant bleeding episodes within the joints, if they're recurrent, they do cause a lot of pain and a lot of problems within the joint, and they require long-term treatment, and they have debilitating effects on the joints long-term. So this can really disable a person and can cause a lot of disability and decrease the range of motion within those joints. This puts a huge toll on the individual, especially if they are a working individual and or even breadwinners of the home, and they need to the family relies on them for their support financially. So this can be very debilitating on a person. This can cause depression, anger, frustration, and can lead to a lot of issues. So if a person does not have a good support system and does not have all of the resources around them, then it can be very, very upsetting and a sad situation, unfortunately, for a lot of people with hemophilia. Genetic counseling is very important in terms of hemophilia, especially if the parents have a suspicion of carrying the disease and passing it on to their child. So they get educated on hemophilia, and if their child, if they do have the disease themselves, if they carry the disease, then they are more educated on it and they are better equipped in handling what it's like to have a child with the disease. So mothers who carry this disease have a 50% chance of passing it on or giving it to their kid. So it's always a 50% chance. Like I mentioned earlier in the video with the red X, they do have a chance of passing it on. So it is important for them to know what this can cause and how they can prepare for it. Typically, a mother can undergo an amniocentesis to figure out if the fetus does have the disease or not. This will help to prepare for afterbirth and what they do after the mother does give birth. Also, if a mother is a carrier, she is more likely to bleed during the whole breathing or birthing process as well as after the birthing process. So it is important to know if she is a carrier or not, so the genetic counseling can help with that in terms of preparing for this event. Newborns can be tested for hemophilia. They are typically testing factor VIII levels with a blood sample. So with this test, they are able to figure out the severity of the newborn's disease, and they're able to figure out a good plan in terms of taking care of the baby and the process of growing up with this debilitating disease.